In this section, I will be administering oxygen. We have our O2 bottle, which you can tell it's oxygen because it says oxygen on the front. We have our regulator, which is a 3-pronged regulator, and the Bodak seal is intact. I will start by putting the regulator onto the O2 bottle. First loosen the regulator. Tighten the regulator. And I will check how much oxygen is in the bottle. It is almost ready for refill. Turn it off, lead the regulator, and lay it on the side. Now I will attach an acute mask to Daniel as he is conscious but needs a bit of oxygen by connecting it at the end and placing it over his head. Dan, can I just get you leaning forward for me? Thank you. I will now turn on the oxygen and set it to 6 litres per minute. It's going to be a bit cold at the start, but that's just the oxygen.
Sweet.
Do you feel the oxygen coming in?
Yep.
Cool. So now I have administered oxygen, I'm going to turn it off. So I'm going to turn off the O2, take the acute mask off Daniel, unplug it, bleed the regulator, set it back to 0, take the regulator off, and lay the oxygen on the side. For this section, I will be demonstrating how to use a bag valve mask and a reservoir. I will start by checking my mask and my reservoir bag by attaching my reservoir bag, pumping it up, checking for leaks. There are no leaks. Attaching my reservoir bag to the other end, covering the side and checking the bag. There are no leaks in the bag. I will then attach my mask and connect it to the oxygen tank. I will turn the oxygen tank on and set it to 15 litres. I will then open the patient's airway by using a head tilt chin lift and support his head with my knees. I will then get a tight seal using a C-grip method and then ventilate every 6 to 8 seconds. I can observe a chest rise. If I could not observe a chest rise, I would use other methods such as an OPA, an MPA, or a jaw thrust. In this section, I will be demonstrating how to suction a patient. I will start by testing the suction by turning it to 350, placing my finger over the hole and putting it against my hand to test the pressure. Because of the resources available, we do not have a charged suction, but I will just pretend that I do. When suctioning a patient, you only suction to as far as the eye can see, and you only suction on the way out. So I put in the rigid catheter and go around using a circular motion and only suction on the way out. You would not use a rigid catheter in a moving vehicle, and some of the issues that can arise from suctioning include induced vomiting, bradycardia, hypoxia, soft tissue trauma, aspirations, and the laryngospasm. In this section, I will be demonstrating how to use an OPA. We would use an OPA if the patient had a GCS score less than 8 or a voice score less than 2. First, you must measure the OPA against the corner of the mouth and the patient's mandible. This is a suitable fit for the patient. To insert, you must insert it upside down until it hits the roof of the mouth, and you turn it 180 degrees and further insert it. If inserted correctly, it will just sit on the top of the patient's lips. A contraindicator for an OPA is a patient's gag reflex, and some issues that could arise from using an OPA is that if it's too large, it can induce vomiting. If it's too small, it could block the patient's airway, and it can also cause damage to the oropharynx. In this section, I will be demonstrating how to use an MPA. An MPA would be useful if a patient has trismus or lockjaw. Before inserting the MPA, I must measure it from the base of the nose to the patient's mandible. This is a suitable fit for the patient, but before inserting it up the nose, I must lubricate the MPA. After lubricating the MPA, I can insert it at a 90-degree angle and push in. If I met any resistance when inserting the MPA, I could twist it 180 degrees or just use the other nostril. A contraindicator for inserting an MPA would be a basal skull fracture. Some other complications that could lead to not using an MPA would be bleeding. In this section, I will be familiarizing myself with the Philips MRX model. First thing I want to do is spin it around and check the batteries by pressing the grey button on top. On both of them, they are both fully charged. If they were not fully charged or needed replacing, I would then change the batteries. First thing I want to do is turn it on and run through an operational check, which I will do by pressing this button, going down to other, pressing operational check, run OP check, and it's going to do its thing. Okay, so the operational check has finished and it is printing out the results. I'll rip off the results. I can go over there. Now we're going to do a test shot. So I'm going to manually put it onto 50. Put the test charge in. First I'm going to exit OP check. Then I'm going to put it onto 50, which I've already done. Just wait for it. Then I'm going to charge. It's charged. Now I'm going to press the shock button. It's shocked into the test load. Now I'm going to show you how to disarm a charge. So I'm going to once again charge it up to 50 and press the disarm button. Cool. Now if I need to change the leads, I'm going to change the leads here to change the amplitude of the waves, go on to display waves, wave 1, 3, up to 4 times, which makes it bigger. Then to change it back, I just put it back down to 1. To change the volume, I go to the volume setting, down to the QRS, up to very loud, back down to off. To put the MRX into AED mode, I twist the knob all the way to AED, and I'll do that. I'm going to turn it back just to normal to on. The non-invasive blood pressure button is here. I press that to start the blood pressure. The ETCO2 is in this pocket. I'll just spin it around so that you can see. I'll take this cord out here. Hopefully you can see this. I'll put the little latch down and stick this end into here. Oh, this end into here, and it will stay in there. And then I will attach this to a mask, and that will record the CO2 levels. Let's save. To change the paper, I'll just whack this open. There's a spare roll in the back pocket. There's enough paper here to do it. Make sure I put a little bit out when I'm closing it. And then to test, press this button. It'll pump out a little bit. The CR puck on the CPR puck on this device is that was a bit premature. I should probably press the button to stop it. The CPR puck is missing on this device, but I'd plug it into here, and that would help me test my depth and my speed of my chest compressions. In the left pocket contains the 3 lead, the 12 lead, and the BP cuff. It also contains the ETCO2 measure and the SPO2 little finger thing. In the right pocket contains all your defib stuff and also your cardiac meds, so like your GTN and your aspirin and stuff. In the back pocket you normally have your electrodes and spare pads and a spare roll. The default lead is the 2 lead or lead 2, and when a lead comes off, which I'll display by taking a lead off, it should just have a flat line like this instead of actually saying that the patient has gone into cardiac arrest, which it has just done. So awesome. In this section, I will be measuring Daniel's heart rate and respiratory rate. For his heart rate, I can measure a couple places, including the carotid, the brachial, the femoral, the radial, and the pedal pulse. I'll be looking for strength and regularity, and a normal adult has a heart rate of between 60 and 100. For respiratory rate, I'll be looking for a correct depth, regularity, and worker breathing, and as a normal adult will have a respiratory rate of 12 to 20. Now I'll take Daniel's radial pulse. Daniel, can I please grab a hold of your wrist and take your radial pulse?
Sure thing.
Now, Dan had in 15 seconds a radial pulse of 15, so 15 beats in that 15 seconds. I also in that time took his respiratory rate, because if you tell the patient that you are taking their respiratory rate, the measurement may be altered. His respiratory rate was 4 in the 15 seconds, so that adds up to 60 and 16, which are both in the regular parameters for an adult male. In this section, I'll be observing Dan's blood pressure. First thing I have to do is gain consent from Dan. Dan, would you mind if I wrap this nice little blood pressure cuff around your arm?
Sure thing.
Okay. I'm just going to wrap it round, making sure that the artery is in the correct position. Get nice and tight so we can get an accurate reading. Dan, if you wouldn't mind, could you just hold this and point it towards me so I can see what's on? So I've made sure I've tightened the valve, and I'm pumping it up to about 140. It is now at 140, and I'm going to place my stethoscope and observe Dan's blood pressure, making sure I'm keeping it up, keeping it level, so that I can see, I can hear. Dan's blood pressure is quite interesting, as it is 120 over 65, but that's alright because I know he's a healthy adult male.
Is it actually?
Yeah.
Oh, that's weird.
Is that alright then? Am I allowed to say that, do you reckon?
Yeah.
Alright, peace out.
Peace out. Is it?
In this section, I will be auscultating Dan's lungs to look for any abnormal sound or noises. First, I will gain consent from Dan. Dan, is it okay if I lift up your shirt and listen to your lungs?
Sure.
Now I'm just going to look 5 sections of his lungs. Nice big deep breaths in for me, please. Cool. Nice big deep breath in. Cool. Nice big deep breath in. Awesome. 2 more. 1 and 2. Cool. So when I was listening to Dan's lungs, I didn't hear any abnormal sounds such as stridor, wheezing, crackling, or rails. In this section, I will be displaying hemorrhage control. Now Dan has cut his forearm/wrist, and from what I can see, it is a clean cut. If it was not a clean cut, I could irrigate it with some saline solution. The first thing I'm going to do is apply direct pressure with my pressure pad, making sure I hold that nice and tight. Thanks, Dan. I'm then going to do a few anchor loops. Fantastic stuff. And once I've done that, I can do some twists to make it nice and tight.
Another thing you can mention, just one thing about with the tourniquet thing is to get pain relief. Like, definitely get pain relief. What's your thing?
Is that nice, Dan?
Not much of a zoom there on this one, but
Is that great enough?
I guess it will do.
Okay, so now I have come to the end of my roll, and I can twist it up and then tuck it underneath. If I had a pin on me, I could also use a safety pin. I'm going to check for Dan's pulse, which I have got, and check his capillary refill, which is fine. If that did not work, I could apply another bandage over top, making sure not to remove the original bandage. If that also did not work, I could apply indirect pressure underneath Daniel's arm to try further stop the bleeding. If that did not work, I can then apply a tourniquet onto Dan's arm, proximal 10 centimeters above the wound. When I put it on, obviously for safety reasons, I'm not going to tighten it fully, but I can twist it to tighten it and then put it under there. I'd also put this over and write the time that I've put the tourniquet. I would also make sure that I've put the patient has been administered pain relief, as it is quite a painful ordeal. If this did not work, I could put another tourniquet, another 10 centimeters proximal to the wound, and then by then hopefully the bleeding would have stopped. In this section, I will be demonstrating how to use a cervical collar. Situations you'd use a C-collar is if the patient had neurological defects, C-spine tenderness, low level of consciousness, he or she was intoxicated, there was a distracting injury, and you'd also have to suss out the mechanism of injury. First of all, I would measure the C-collar using my fingers. This patient appears to be irregular. I'd have Dan supporting the head/neck, and I'd just insert it underneath the patient's head slowly and carefully, and then flip it over, grab the Velcro strap, strap it nice and tight. I'd also make sure that Dan kept supporting the neck. Some complications that could arise from C-spine is increased intracranial pressure. In this section, I will be covering fractures and immobilization. I have come to a patient who has a suspected mid-shaft tibial fracture. I will start by assessing the condition of both feet. So I'll look at temperature, some pulse, colouring, all looks normal. Swelling, there's not much swelling. I will then test for sensation. Hey mate, can you feel this?
Yeah.
Where am I scratching?
Under my foot.
What toe am I wiggling at the moment?
My middle toe. That hurts.
Oh, so we've got full sensation and everything looks pretty normal. So I will then offer the patient some pain relief as they are in a lot of pain. So I'll give them some Internox. I'd ask, hey mate, do you have any allergies?
No.
Have you been diving in the last 24 hours?
Nah.
There's no suspected bowel obstruction or pneumothorax. So then I, tell them how to take the Internox. So mate, you're gonna put this in your mouth and you're gonna take 10 deep breaths for me. You might feel a bit sick or lightheaded or even euphoric, but that's just the gas working. If it gets too much for you, then you can take it out. It's a self-medicated drug, so just take it as you feel is necessary.
Okay.
Awesome. So now I'm going to splint the fracture, and I'll get my buddy Dan here to come and support the leg and lift it up slightly as I slide the splint underneath. Make sure that is nice and good. I'm going to then support the end. And Dan, could you just hold up the sides for me?
Sure thing.
Awesome. Now I'm going to get some tape and then tape up the end. I'm now going to support proximal and distal to the fracture using these rolled up bandages. So I'm going to get Dan to just lift the leg slightly. I'm going to slide it underneath. Go proximal. Cool. And I'm going to get Dan still supporting it. And I'm going to go distal. So after doing this, I'd make sure to reassess all my temperature, my circulation, my cap refill, sensation and all that. And I also make sure that he's taking the Internox gas and that it's working sufficiently. Hello, I'm from the ambulance. Can you hear me? Can you hear me? Patient is not breathing. Dan, could you please start on compressions?
Sure thing.
AU21 to control. R49 requesting after feed.
Analyzing heart rhythm. Do not touch the patient. Shock advised. Charging. Stay clear of patient. Deliver shock now. Press the orange button now. Shock delivered. Paused. Start CPR.
When this analyzes the patient's heart rhythm, we'll swap over.
Okay.
You got good depth and good speed. Did anybody witness the patient collapse? No witnesses.
627, 30.
Stop CPR. Analyzing heart rhythm. Stay clear of patient. Analyzing heart rhythm. No shock advised. Paused. If needed, start CPR.
Easy as.